Good day, everyone. I'm Bella, the moderator for this webinar. I welcome everyone for today's webinar, Emergency Services, Emergency Procedures, and EMTALA Obligations, CMS Hospital Conditions of Participation 2025. I would now like to introduce our presenter for today, Laura A. Dixon. Laura A. Dixon, BSJD, RN, CPHRM, recently served as the Regional Director of Risk Management and Patient Safety for Kaiser Permanente, Colorado, where she provided consultations and resources to clinical staff. I would now like to hand over the floor to the speaker.
Okay.
Over to you, Laura.
Okay, thank you, Bella, and welcome everyone. What we're talking about today are the emergency services and procedures that you have to have available in your hospital, being credited or actually certified with CMS to participate in Medicare and Medicaid. And these things have to be available whether it's a Medicare, Medicaid patient or a private pay patient. As long as you participate and accept the funds, then you have to meet these requirements. The second portion is EMTALA. Now, briefly, EMTALA is actually a federal law that CMS wove into their conditions of participation. So again, that way you have to meet all of those requirements if you're going to be considered compliant with the CMS requirements. So I'm going to start briefly on introduction of emergency and why are we here? Appendix A for acute hospitals. You have two sections. Critical access hospitals, you're in one. So I did mention Appendix V is EMTALA. It applies whether a 500-bed educational teaching hospital or a critical access hospital. And so for acute hospitals, there's your tag numbers. So again, those initial ones are for non-participating hospitals. The second one is for those who do participate. So roughly, if you have an emergency department, you have to comply with that section. And the policy and procedures also have to address what happens if what that patient needs exceeds your capacity. So let's go to the main bulk within Appendix A. That's where the main component is for emergency services. Overall services have to then work with other departments like X-ray. They have to be able to provide that emergency care accordingly when needed, appropriate times, and in a safe manner. What if you have an urgent care clinic and it's affiliated with your hospital? You have to have supervision by a qualified member of your medical staff, but they also need other people there to help out, other medical and nursing personnel. So on the surveyor, they're going to make sure you have enough qualified staff, whether it's nursing or medicine. Now, there's some new information that came out. It came out last year, late last year, 2024, November. And it talks about emergency service readiness. It will go into effect July 1st, this component of it. So here's some of the provisions. That's equipment, supplies, and medication. Along with provisions, there must be staff training. These are all new, by the way. First off, you have to identify what staff has to be trained annually on these protocols. I'm going to switch over to critical access hospitals, your 25 beds or less that are located in that rural area. Now, these are very similar. They are. You have to have a qualified medical director according to the criteria from the medical staff. You have to determine who and how much you need. The care includes provision for respiratory services. Now here CMS gets a little more specific. Now here's where there's some difference between an acute hospital and a critical. Handling, storage, and dispensing of therapeutic gases, bronchopulmonary drainage, ventilation. Are you providing care according to what your policy and procedures say? Your services likewise have to be available 24/7. On the emergency drugs that we need to have available, they list them out. You have to make sure your staff know where this stuff is located. Okay, blood and blood products, I said I would cover it. Storage has to be under the control and supervision of someone who's qualified. That's a pathologist or other qualified physician. You have to have a practitioner who's trained in emergency care. Well, what if you have an RN on staff? Then back over to some other general information. Coordination with EMS. Now, this is part of the provision of services chapter. It doesn't matter if you're in acute hospital or critical access. It's the same information regardless. Now, I'm also going to talk about pregnant patients again. There were some changes that came out in November of last year. So here's a basic concept. Physicians can be excluded from Medicare. Now, the basic section is just simply saying all hospitals that participate are governed by this. EMTALA itself applies to anyone who comes to the ED asking for care. There are 3 criteria on what's a dedicated emergency department. What's capability? What is that specialized capability? Capacity means that you can accommodate this person for examination and treatment. Medical screening exam, well, we do that to determine, is this person in trouble? Are they having an emergency condition? What do you do about those pregnant patients? Otherwise, an emergency medical condition has to manifest itself in sufficient severity and symptoms. Otherwise, we stabilize our patient. But the general rule, we know if a patient has an emergency medical condition, we can't transfer unless it's appropriate. If that physician is not there at that time, it can be made again at the request of the patient or legal guardian. Say if it's a minor, the parent can do so. Now I'm going to talk about some new services and requirements that came on. Patient, they've been turned away from emergency department. You have to meet these maternal health conditions in order to avoid termination from the Medicare and Medicaid. Now, this goes into effect January of 26. So starting with organization and staffing. Of course, they have to be well organized. Next component, delivery of services, basic equipment. The third component is staff training. That means you have to have policy and procedures to make sure staff are trained. The fourth component is QAPI, 4 minimum requirements. You analyze and prioritize outcomes and disparities. Leadership has to engage in these QAPI projects. They have to. And then emergency services readiness. You have to set aside enough provisions for emergencies, whether it's medications or equipment. And then transfer protocols. This is the last component. Annual training to that staff who need to do this. Here's the implementation phase. This is coming to a close here. The effective date of the new rule overall was January of this year. But there are 3 phases of implementation. So again, they phased it in over 2 years to give you some time to catch up and make sure you're compliant. And with that, that's the conclusion. Thank you everyone for attending. Some of these new regulations may or not be changed. It's been quite an interesting political environment right now. So as it is to this day, those are the requirements that are necessary to take care of patients, whether it's a mass trauma, somebody who's crashing on your floor. So whatever it happens to be, that's what we do have to comply with. I do want to thank everyone for attending and thank you for taking care of your patients and what you do to get them to the best level of care. So thank you. And Bella, I'll have you go ahead and close us out.
Yes, thank you so much. And thank you so much again, Laura. So that concludes all the session for today. Thank you everyone for participating. You may all disconnect now. Thank you so much. Have a great day.